Thank you very much. I'm sorry I don't speak Spanish, and then my presentation will be in English. I really thank very much Antonio and Eduardo to give me the privilege to be here. It's for me an honor to be here, and I thank Antonio and Eduardo for giving the opportunity to see our Mexican colleagues, and thanks again for your warm welcome and your friendship. My topic is regarding our approach. It's not exactly a classification, but it's the introduction to our approach and our algorithm in treatment of diabetic patients or patients with tibial disease in our center. You know that we have different kinds of tibial disease. We have stenosis, single or multiple stenosis in tibial vessels, or occlusion, different length of occlusion, short occlusion, or long occlusion. And you know that the first classification of the first guideline was published in 2000 with the task. And if you look in the task classification, you can see 4 different groups of lesions, task A and B, with the treatment of choice, endovascular therapy, and task C and D, the treatment of choice or surgery. But if you look inside the task C, you can see single stenosis between 1 and 4 centimeters, occlusion between 1 and 2 centimeters, extensive stenosis of tibial trifurcation, and the type D you can see tibial occlusion more than 2 centimeters, and diffusely diseased tibial vessels. Then we started with our approach with this guideline to treat patients with tibial disease in anterior, posterior, and peroneal arteries with different kind of technique, simple PTA or PTA of perforated branches or PTA of foot and ankles arteries, of kissing balloon techniques or PTA and technique. But in our clinical practice, we had the opportunity to define that there were some limitations in the task classification. The task classification is only a classification regarding the length and the quality of lesion, no evaluation about the runoff, no evaluation about the profit lesion, and no evaluation about the quality of venous, of autonomous venous, that is very important in the decision of revascularization of the legs of this patient. Regarding the length, we know that Exopania underlined the role of the length in the technical success of PTA, and we agree totally with this first paper published by Exopania regarding this topic. But you know in daily practice it is possible to have a good technical and angiographic result if you treat patients with 4 cm occlusion in the anterior tibial artery, or if you have occlusion of the tibioperoneal trunk between 2 and 4 centimeters, like task D lesion. And I remember you, task D lesion is only for surgical approach. We can treat this patient with different kind of technique, like kissing balloon technique. We published this technique in 2008, with good angiographic and good clinical results. But we can treat at the same time long occlusion in the ankle and the foot in this kind of patient with good angiographic and good clinical results. Then the first idea in our clinical practice was to change the classification of tasks and to propose in our clinical practice another classification regarding the possibility to use endovascular treatment only in patients with stenosis, single or multiple stenosis in tibial vessels, and in case of occlusion less or equal or 4 centimeters. In other cases, our indication were bypass surgical treatment of this group of patients. The second point was to evaluate the runoff. In our experience, we published in 2007 the endovascular treatment of peroneal artery disease, and we defined it as very important to know the runoff, because in patients with poor runoff, the results regarding the immune service are lower than patients with good runoff. And what does it mean, poor runoff? Patients without inline flow to the food after the endovascular treatment with peripheral arterial-occlusive disease. This is a patient with trophic lesion in an adult center. The first indication was endovascular treatment of the perineal artery, but with poor runoff in this kind of patient. The result was after 1 month no clinical success in this patient, but the patient was evaluated in our center. We defined the presence of the dorsal space with low resistance in the foot, and we decided to make a bypass to the tibial arteries in the foot, and the dorsal was after 8 months the clinical success in this patient. Then we introduced in our clinical practice, in our algorithm, not only the extension of lesion, but the quality of the runoff in this group of patients. The other point was the clinical aspects of the trophic lesion in patients with gangrene in this group of patients. Here underlined the role of trophic lesion. And we agree totally with the SDS experience, because we, in our experience, we evaluated the result of PTA in tibial vessels. We defined that one of the major negative factor for limb salvage is the trophic lesion and the quality of the trophic lesion. And then it's very important to define pre-op if we have different types of lesion with or without infection, the extension of trophic lesion. And according to the Texas, in our department, we use it not only for after classification. We know it's important after classification, but in patients with diabetes disease, we needed to evaluate exactly the type of trophic lesion, and we generally classify our patients according to the Texas classification. And we defined that in patients in 200 PTA, that in patients with infection, the percentage of limb salvage is lower, statistically lower than patients without infection. Then, in patients with infection, probably it's better to use surgery. We don't think that this is the solution, because in patients like this, with infection in the plantar area of the foot, probably would be a good idea. But in patients with infection in the dorsalis area, in this patient with the tibial vessel disease and the possibility to make a surgical vascularization of dorsalis spaces, we think is not a good idea in patients with an infection of dorsalis area to treat this patient with surgery, but we think it's better to treat this patient with endovascular therapy to treat the infection, like how you can see on the right side. Then in this group of patients with infection and that need a long time of healing, we think it's very important not only the endovascular treatment, but the follow-up in this patient, because frequently, you can have a restenosis in PTA, and then we have to treat in these patients at different time. We have to re-treat these patients for restenosis to guarantee the good healing of this trophic lesion. Then we added in our algorithm not only runoff, but even the Texas good classification to decide which kind of treatment is possible to use in a different kind of patient with tibial vessel disease. The last point was the availability of autologous vein in this patient. You know that we can have different possibilities. We can use the ipsilateral or contralateral saphenous vein, or arm vein, or less saphenous vein. Then we need to define pre-op what is the quality of the saphenous vein before to treat patients, before to decide which kind of revascularization we need in a patient with tibial vessel disease. And if we have a good autologous vein, we can go directly to the bypass. But if not, what is the alternative in this patient? We had experience, and we published last year our experience about 153 cases of bypass to the ankle and foot, and we included in this group of patients are homografts. But you can see here that primary pathology, one of the major negative factors for primary pathology was the use of homografts. Then we introduced homografts in our algorithm, but only in patients with the same food associated with infection or traumatic stroke lesion, and in patients with Texas multiplication less than 3. Then, if you complete our algorithm, you can see that in case with trophic lesion with infection, we can go versus the PTA or surgical approach according to the localization of the infection. And if you look to the poor the runoff, in patients with good runoff, generally we treat patients with PTA. In patients with poor runoff, generally, if there are good arteries, quality of arteries regarding the diameter and the hemodynamic aspect in the ankle, we prefer generally bypass the ankle in foot. We decide only to treat patients with poor runoff with endovascular treatment only in patients with a very high risk for surgical revascularization. Then, in conclusion, ladies and gentlemen, we think that in our experience, we need to use for to define the best choice for revascularization in patients with intermittent disease. We think we have to evaluate always the extension of the disease, the quality of occlusion, the runoff, and the quality of the disease. According to these 4 variables, we can decide exactly which kind of revascularization, or in some cases, the major amputation. Thank you very much for your kind attention.